We ready to go, Cheryl?
Yes, we are.
Okay. Okay, I think it's time for us to start. I see we've got 24 participants. I'm just going to share my screen. There we go. Okay, so first of all, welcome everybody. This is the weekly GECO meeting that we present, hosted by the Gastro Foundation, but in association with Project ECHO of the University of New Mexico. The last count, I think we had over 70 registrations, and from a total of 19 countries, of which 18 African countries, sub-Saharan African countries, and notably many participants from West Africa that we're really happy about. So today we're going to address the topic of HCC treatment in sub-Saharan Africa. I'm just going to briefly share a few pictures with you. Just in terms of questions, if there are any questions, you're welcome to put them into the chat. And then we can address them from there. And at the end of the presentations, we will also have time for questions and hopefully a discussion. So I'm going to present the speakers a little bit later, but just as an introduction, we know that the treatment of hepatocellular cancer in Africa, and especially sub-Saharan Africa, is a sad and in a way disturbing story to tell. If you go back in time, not so long, about 6-7 years, this is a paper that was published from Ghana, looking at a large cohort of patients where none of the patients were actually treated with curative intent. With a retrospective analysis of the folders in these patients, some of them could have been treated, but weren't, and probably to do with the resources. This is a paper, I think a landmark paper, that was published by Lewis Roberts' group in 2016. It was a survey amongst a number of countries that you can see on the map there, that again painted a really disturbing picture, with less than 1% of patients treated with curative intent, and even patients with palliative interventions like TACE, very few patients benefited from those treatments. This is another paper, and one of the few in the literature that published on outcomes of HCC in Africa. A paper from Senegal that here listed the treatments that patients had there. So you can see a total of 229 patients, where only 12 of the patients eventually underwent surgery. There were a few ablations, and there were a number of TACEs performed as well. If you look at this paper, the survival of patients that underwent hepatectomy, and these are the patients that survived at least 1 year, that about 2/3 of the patients survived a year. I think those are reasonably good results if one keep in mind all the challenges we face, and the range of the survivors there were 2 to 5 years. And then for the radiofrequency patients, there was also a survivor, and also for a patient that underwent percutaneous alcohol injection. But again, if you look at the whole cohort mortality, you can see that about more than 1/3 of patients never made it out of hospital, and probably just short of 90% of patients did not survive a year. So it's really a big pleasure for me to welcome Professor Elie Keli from Abrasion in Ivory Coast, that is joining us today. And he's going to share with us his or their experience with treating HCC in their country. Following that, Mark Bernon will just show you some results of a recent analysis we've done of patients treated in a hospital in Cape Town. And then after that, we'll have a discussion. So first of all, Elie, thank you very much for agreeing to speak today, and we're really looking forward to your talk. So I'm going to stop sharing, and then I'm going to start sharing your presentation, and then you can just unmute and start presenting. Just 1 second. All right, so I'm sharing the screen. So Elie, if you can just unmute your microphone, and then you can start presenting, and you can just tell me when I should advance the slides. So if you just click on the little microphone. Elie, we can't hear you. Just click on the little microphone just to unmute. There we go.
Thank you. It's okay?
It's okay. We can hear you.
Okay. I have to speak about treatment of hepatocellular carcinoma in Côte d'Ivoire. So, slide, please. Slide. Okay. We know that hepatocellular carcinoma is a malignant disease with universally non-lethality rate. The disease is mainly at advanced stage at the diagnostic term. The management of this disease can be made with various methods. The Barcelona Clinic of Liver Cancer is the standard for staging of the patient. However, the final decision is influenced by factors as healthcare accessibility, infrastructure quality, and local expertise. Slide, please. So, for this presentation, I would like to let you know my country, to remind some current evidence of epidemiology of hepatocellular carcinoma before making a presentation on our management experience of this disease. Slide, please. Côte d'Ivoire is located in the western part of Africa. It is a square-shaped country with 300,000 square kilometers. And we are bordered in the south by Guinea Gulf, in the north by Burkina Faso and Mali, east by Ghana, and west by Liberia and Guinea. Slide. There are about 26 million inhabitants, and when you look at the population pyramid, you can't notice that there are two predominant age groups: the children, who represent 39% of the population, and the prime worker age, which represent 34% of the population. So it's globally a young population. Slide, please. The country belongs to the lower middle income group of the World Bank classification, with a gross domestic product of 61 billion US dollar in 2020. The economic growth is among the fastest in the African country, and we are now a GDP growth rate at 7%. Slide. About the system, the healthcare system, The systems are funded globally by the government, and the access to healthcare are on the basis of pay out of pocket for the major part of the population. And concerning the hospital, we had about 12 tertiary hospitals in Abidjan, and we should know that universal HPV birth dose vaccination start here by 2005. Slide, please. Slide, please. Concerning the epidemiology, let me give you some current evidence of the disease around the world. Slide. Slide, please. Globally, HCC is known to be the 6th commonest cancer and the 4th commonest cause of cancer-related death. It is estimated that the incidence of the disease will rise by 2025 to be more than 1 million new cases per year. The risk factors are known: it's cirrhosis, chronic HBV infection, chronic HCV infection, and alcohol use. Slide, please. Slide, please. Play. Concerning the disease burden in sub-Saharan Africa, we know that it's the second leading cause of cancer-related death for men and the 4th in women during 2020, with an age standardized mortality of 8.2 for men and 4.2 for women. The risk factors are the same, with a particularity with dietary aflatoxin and iron overload. Slide, please. Slide, please. Okay. This is the epidemiology of this disease in Africa, and at the bottom we can see that West Africa have the great incidence and the great mortality rate. Slide, please. When you go inside this number, we can see that in West Africa, the disease have a very range number of incidents. So our country is the 11th when you take all the 16 countries of West Africa, and we belong to the intermediate endemic risk group with incidence about 8.4 and the same number for the mortality. Slide, please. Concerning the management of this disease. Slide. The quality standard of human resource for this management is a multidisciplinary team, which is composed of an hepatologist, an hepatobiliary surgeon, an oncologist, an radiologist, and a pathologist. Slide, please. We got a team with 7 surgeons, 1 hepatologist, 3 radiologists, 1 interventional radiologist, and oncologist. We are now working to set up a liver transplant program with a team coming from Egypt. Slide, please. The quality standard of hepatobiliary equipment for radiology are multi-site CT scan. We got 12 here in Côte d'Ivoire. A 3 Tesla MRI machine. We have 3 here, and the C-arm fluoroscopy. For the interventional radiology, we have 1 center when we have a microwave ablation capacity. Slide, please. This is our operating room, newly equipped by a duplex ultrasound, a cell-server machine, and a CUSA generator. So we have the possibility now to make more hepatectomy. Slide, please. Now, concerning our experience for the treatment of this disease, slide. It's experience from 4 hospitals. We last from January 2012 to June 2020. The data are based on imaging data, alpha protein value, clinical data. And our patient here was evaluated according to the Barcelona Clinic Liver Cancer Statistics System. We will see the demographic, clinical, and therapeutic parameter later. And the results are from 4 centers, 3 tertiary hospitals, public, and 1 private clinic. This data have been done by a hepatologist, surgeon, interventional radiology, and 1 oncologist. Slide, please. When you look at this table with our patient, it's about 272. And the major part of this are men, more than 50%. The median age is 48 years, and hepatitis B viral is the main risk factor in our study. When you look at the alpha fetoprotein value, more than 50% have a value above over 400 unity. And our class stage B are about 37. Slide, please. This is a typical picture of a disease in our country. It's a case of a 2nd-year-old man who had a follow-up of 2 years when we discover this lesion, the tumor of 9 centimeters on this segment H. Slide, please. This is our treatment option with 9 cases treated by surgery. It's about 7% of all surgery. Ablation, local ablation was done in 16 patients. It's 6% of all the surgery, and 237 for the palliative component of the surgery. Slide. we had about, we can see 16 hepatectomy, mainly for the left side. Mainly for the left side. We have in this report one case of liver transplantation is that is made in Cairo with our Egyptian team. Slide, please. About our results, the morbidity rate is very, very high, about 47%. And our mortality, perioperative mortality, is about 37%, mainly due to liver failure. And the recurrence rate is about liver in 43%, and the recurrence time don't last 24 months. And our median survival is about 18 months. Slide. About the local ablation technique is mainly by percutaneous microwave techniques. We use about 62.5% of this group. About the radiofrequency, the two cases has been done outside of the country. And this case of transarterial chemoembolization has been done here, but the result is not very good. Please, slide. This group of treatment, local ablation, are not very, very good for us. We experience a very, very high rate of recurrence at 3 months, about 50%. Slide, please. So I can see to conclude that the disease, hepatocellular carcinoma, is frequent in Côte d'Ivoire, with probably an underestimated burden. The predominant presentation of that cancer is advancing case, and the commonest curable profile is that of a tumor of 6 to 8 diameter in a young man with a preserved liver function. We find that we need to have more multidisciplinary management meeting to have a better selection for the treatment. And for that, we think that a guideline made by African will take account our local capacity to treat our patients. This is my presentation. Thank you for your attention.
Okay, so Elie, thank you very much for this very nice presentation. Well done. I just want to see if there are any questions in the chat. I don't see any questions. I think we can maybe just take a few questions before we start with the next presentation. We are well in time. Okay. If I just ask you, I saw in your series of patients that quite a lot of patients were, or not so many patients were advanced in the, if you look at the Barcelona criteria, you had quite a high proportion of patients that were B. And And is that due to the fact that you've got screening and surveillance programs that are quite effective in Côte d'Ivoire, or how does it work?
Yes, I think we have here 3 hepatologists departments, and they have a political of follower the patient, the cirrhotic after being hospitalized in their department. So we got many cases of this kind of patient, so as staging B.
And also for patients with hepatitis B, are they also included in the screening programs?
Yes, it's when they are finished their decompensate cirrhosis episodes, when they go out of the hospital, they are in a screening program of HCC.
Thank you. I see there's one question in the chat group. There's a second one coming up, but from Julian Utley, do we have any idea about the reason why in Guinea there is such a high incidence of HCC? You're not from Guinea, so maybe you can't answer from Guinea, but I see we've got Wendy Spearman as well in the meeting. Maybe she can comment on that. Wendy, if you can speak, or maybe Elie, you can tell. What do you think the reason is for the very high incidence that is reported from Guinea?
My thought is that our burden of the disease is underestimated, and I can see that when we look at the data of Guinea, when you look at the data of Ghana, when you look at the data of Burkina Faso, there are high number of cases. So I think that our cases are underestimated. We should make more investigation to have a better number of reality.
Okay. Then there was just a second question here from Wisdom. What is the
I can hear you.
Yeah, no, sorry. It was just a question from Wisdom here. He missed it, what the percentage of hepatitis B and HIV was. I still have the slides up here. So hepatitis B, I understand it was 55% in the population that you treated. And then he also, HIV, how high the incidence of HIV was.
Globally, we have about 5% of HIV in the population. I haven't looked at this in my patient. In this patient, I can give you the number exact of HIV patients.
Okay.
Ed?
Yes, Wendy. Thanks.
So, I mean, I think if you look at the prevalence of HCC, I mean, particularly in Western Sub-Saharan Africa, it's really very, very high. I think it's probably driven by hepatitis B, the contribution of hepatitis C, and the very, very good studies coming from the Gambia, which showed that actually the patients born to mothers who were E antigen positive or even surface antigen positive had a very high risk of HCC presenting in their early 20s. So I think it's a problem of not identifying mothers who are surface antigen positive, initiating tenofovir prophylaxis. the birth dose vaccine, unfortunately, has only come into most countries. I mean, there are only 14 out of countries that have the birth dose vaccine, and that's only been actually introduced in sort of the late 90s, mid 2000s. So I think we're still seeing the problem of mother to child transmission and the high association of HCC. And the lack of, the lack of point of care diagnostics to actually pick up these patients early and initiate therapy as adults.
Thank you very much, Wendy. I don't see any other questions. So if there are no more questions, I think we can continue with the next presentation. So it's Dr. Mark Bernon, a consultant surgeon here at Groote Schuur Hospital and the University of Cape Town, that is just going to give you an insight of the proportion of how we treat the patients here, how they present to us, and then some results as well. Thanks, Mark.
Thanks, Ed. Is it sharing?
Yes.
Okay, great. So I think we have the same problems in South Africa that are experienced throughout sub-Saharan Africa. I'm going to rehash them, but I think it's important to identify what the problems are. So hepatitis B is endemic in our country. Patients are often infected in childhood. There is a lack of adequate screening programs, which means that patients often present with advanced disease. Access to centers with curative intended treatment modalities is very limited. If you take South Africa, whether you consider the private and if you consider the private and the public sector together, there are only 2 centers in the whole country that offer all the curative intended treatment modalities. Added to that, HCC is not a priority for lots of governments. It's underreported in national cancer registries. And there's another factor is that there's really inadequate reporting of imaging investigations and a lack of standardization and a general lack and reluctance to diagnose HCC purely on imaging findings. And that's one of the reasons why there's this underreporting in cancer registries. Over the last 5 to 6 years, in the hospital that I work in Cape Town, there's been a number of changes, and I think there's been an improvement in the HCC treatment, but there's still a lot of room for further improvement. And I'll present our data, and you'll see what I mean. And some of these changes were not things that were specifically directed at HCC, but we've implemented much better multidisciplinary discussions for all cancer cases. And we now discuss all cancers, even if we think that they are potentially palliative. We've set up a HCC registry. We have increased screening of high-risk patients, but that's really limited to our hospital. There's a big problem with screening in peripheral hospitals and peripheral centers. We've attempted to try and standardize the reporting of imaging, and we've started to try and use the LIRAD system. And then I think because we didn't have all the modalities available, and the disease is really different to the disease that's found elsewhere in the world, there was some hesitancy initially to really adapt international guidelines for treatment. And I think we've become better at trying to do that. We can't always do it, but there's certainly been an increased use of TACE, mainly as a palliative treatment. There's been an increase in liver resections in patients who are cirrhotic and in patients who have hepatitis B. And we've started considering HCC patients for liver transplantation in the last 5 years. And we've also done our first transplant in a patient with active chronic hepatitis B in the last 5 years. So I think those are if you add all of that together, it has made a change. So we've done an audit of our cases over the last, basically, if you look, we've included all patients from the 1st of July 2015 to the 30th of June 2020, and we followed up just the patients who had curative intended treatments until the 31st of August 2021. So much like the data that Professor Keli presented, you can see we had 152 patients who presented with HCC in that period, and only 13.8% of the patients were treated with curative intent. So that was 21 patients. Almost, well, 85% were treated with palliative intent. Of the curative intended group, 6 had liver transplantation, 12 liver resection, and 3 local ablation. So let's move on. So if you look at the total cohort of patients, the majority were male, as is reported in most series. The average age in our series was 51, with quite a wide variation, and our youngest patient was 12, the oldest one was 86. The incidence of cirrhosis was surprisingly low, but we think that that's related to hepatitis B being the most common etiological factor. In this series, it was Hep B was diagnosed in 60% of the patients. This, I think, is a select group of patients because they were referred, a lot of them, from other hospitals. So you know, patients who have very advanced disease or very poor liver function are obviously not referred to us. So there's a little bit of a selection bias in our data. So that's why I think a lot of the patients with Child-Pugh A and B, and a lot of the patients with very bad liver function, were not referred to us. Similarly, with the BCLC stage. So I've just highlighted it here, but you can see how in our series of the patients presenting to our hospital, 66.4% were either BCLC stage 0, A, or B. So obviously it's the 0 and A patients that are usually the ones that you can offer a curative treatment modality to, and the Bs are the group that often end up getting palliative treatment with TACE. 36.2% presented with advanced stage of disease. So if you look at you divide it up into the curative and palliative groups, as if there were no real big differences apart from the 2 things that I've highlighted. The incidence of cirrhosis was higher in the curative group, but I think that's because of the way that we diagnose cirrhosis. So cirrhosis was either diagnosed on imaging or on biopsy, and obviously if you resect a patient or transplant a patient, you have a specimen. So I think that that's also a selection bias. I don't think that there's actually a higher incidence of cirrhosis in the curative treatment group. I just think we're failing to diagnose cirrhosis in some of the patients in the palliative group. As you would expect, there was a higher incidence of patients with early BCLC stage in the patients that got curative intended treatments. So we're going to focus on this group of patients for this talk. So the 21 patients who had curative intended treatment, and I'm going to start off with the transplant patients. You can see what similar sort of demographic features to the entire group, but all of these patients had cirrhosis. And I've listed all the transplant patients so we actually listed 7 patients for transplant. You can see patient 1 did not get transplanted and died after being on the waiting list, after progressing on the waiting list after 190 days. That patient did not receive TACE as a bridging therapy, and all the other patients that we have transplanted did receive TACE as a bridging therapy. All of these patients are still alive, and the median survival at the moment is 54.3 months, and the range in there is 29 to 60 months at the moment. So our transplant patients have done quite well. Our resection group consisted of 12 patients. 50% of them were cirrhotic. We only had 1 Child-Pugh B, the rest were all Child-Pugh A. If you look at our results, so 50% of the patients are alive. So we're quite conservative when we select these groups of patients, and if the patients are we consider them borderline resectable, or they have high viral load, we'll often treat them with TACE as a sort of downstaging or bridging therapy before we consider resecting them. The overall median survival in this group, if you take the entire group, was 24 months. One patient died after 4 days of surgery from post-hepatectomy liver failure. The longest surviving patient is 71.6 months. If you look at the patients who died, the 4 who died, they died quite early. And 2 of the patients have been lost to follow-up. We only performed local ablation on 3 patients, and one of those patients died after 32.2 months. The other 2 patients are still alive. So the median survival in that small group of patients is 45.3 months. So I'm just coming back to this slide that I had in the beginning, and I just want to give a sort of an overview. So in our series, by far the majority of patients, like I said in the beginning, are still treated with palliative intent, and that's despite us being in a relatively well-resourced hospital. Liver transplantation has been performed on a very small number of patients, but with good outcomes. I think we are very selective in the patients that we choose for liver transplantation. Liver resection, we've got a 50% survival rate, and then local ablations we performed in a small number of patients. So in conclusion, I'm just going to move on to the next slide, sorry. 64.8% of patients in our series presented with BCLC stage 0A or B disease. That definitely doesn't represent, or is not a true representation of how patients present in South Africa, and it's a selection bias related to our hospital. We only managed to treat 13.8% of patients with curative intent. And the survival of patients treated with curative intent was in keeping with survival data from better resourced centers. And I think it just shows that there's a few things that we need to consider in sub-Saharan Africa. We need to try and improve our screening programs. We need to try and have earlier detection, but that's not enough. We need to start having more curative intended treatment options, resection and ablation. And I think although transplantation is a nice thing to have, of all the curative treatment, or all the treatment modalities, it's probably going to help the least number of patients. I think TACE is probably going to help the largest number of patients, although it's not a curative intended modality, followed probably by resection and then ablation. So like I said, we need to have improved screening of at-risk patients, and not just at big referral hospitals, but at smaller peripheral hospitals. We really need to have standardized radiology reporting, and we need to emphasize that biopsy is not a big factor in diagnosing this disease. And I think in teaching hospitals, we need to have a commitment to try as best we can to treat patients according to international guidelines where possible. Thanks very much.
Thank you very much, Mark, for a very nice presentation. I see there is one question from Wisdom that we can take first, and then we can see if there are more questions. And I have a few questions as well. And please put your questions into the chat thread here, or just raise a hand if you want to ask it. So Wisdom asking, the Cape Town series, that you also look at HIV co-infection, hepatitis B and hepatitis C patients, and what was the role of HIV, or is it not relevant? Mark, I don't know if you want to answer that question. You want to ask Wendy?
I think I'm going to just say something, but I think I'm going to defer to Wendy. So we didn't, in this little study that we didn't look at HIV co-infection, but I think we could get that data. I do know that none of the transplant patients were infected with HIV. I don't think it's a contraindication to transplants. I don't think it's a contraindication to any of the treatment options. But but I think Wendy might have more to say about HIV and hepatitis B co-infection, and she knows a lot more about it, especially in Cape Town, than I do.
Yeah, so in terms of HIV and hepatitis C co-infection, hepatitis C is really not a problem in South Africa. I mean, in our general population, there's really only a 1% prevalence. And we see it mainly in vulnerable populations, key populations, such people who inject drugs. So hepatitis C, not a major problem in terms of HIV co-infection. But certainly for HIV hepatitis B, the patients that we see tend to present late, very aggressive, and they've usually either defaulted therapy or they've actually presented late with very low CD4 counts, less than 50. So very aggressive disease, multifocal. And they tend to actually, I mean, we tend to see them in the general medical wards and they demise quite quickly. So they really don't even get to the stage of being considered for palliative. It's really just pain control. So certainly aggressive disease in those with HIV, hepatitis B co-infected, but unfortunately they're presenting very, very late with uncontrolled HIV and hepatitis B.
Okay, thank you so much, Wendy. I see Karan Gandhi's got his hand up.
Yes, good evening. Thank you very much, Prof. Thank you to both the speakers for very interesting talks. I actually have two questions. The first one is for Professor Keli. Prof, how often do you see aflatoxin as part of the etiology for HCC in Ivory Coast? Because in your study you showed some data with cirrhosis and hepatitis B, hepatitis C, but do you see aflatoxin often in Ivory Coast? And my second question would be to Mark. Mark, in terms of the transplant candidates, you actually mentioned that all of them had a bridging taste before the transplant. Is this because the patients are waiting long on the waiting list for organs to be available, or is it because they present at a slightly more advanced stage, for example, a Barcelona B, and you downstage them to a more transplantable criteria? Is it bridging for downstaging, or is it bridging because we're waiting for organs? Thank you.
I think we can start with Professor Keli. I see he's unmuted.
Okay.
If you didn't hear the question, just the role of alpha toxin as an etiological factor in your country.
Okay, what I read is about generality, but in our practice, we are not looking for this etiology. So I can give a real rate of this part in the etiology.
Okay. Yeah, thank you very much. Yeah, Wendy, just on that topic, is that still a big issue for us in South Africa, aflatoxin?
So aflatoxin, not really a problem. I mean, obviously, where KZN borders with Mozambique, that's a potential problem. But on the whole, aflatoxin in South Africa, not a big contributing factor. But certainly in the sort of subtropics, topics of Africa is a major problem. So Ghana particularly, and maybe I think Mary Afeni is on the line. She might be able to comment on that.
Mary, if you're on, you want us to comment on that?
Yes, a couple of studies done have proven that we have aflatoxin B1 in Ghana here, in high levels, in our grains, and some of our foods, corn and granite especially. So we have aflatoxin B1 as a problem in Ghana.
Okay. Well, thank you very much. If no more questions about aflatoxin or comments, Mark, just the question about
so if you read the international guidelines, they say if your patient is likely to wait for a transplant for more than 6 months, then you should do a TACE. So I mean, we've only listed 7 patients for HCC and transplanted 6, and the first one died waiting for liver, and he was not a resection candidate, and most of the transplants are not resection candidates. That's why we've listed them for transplant. Most of our patients are actually transplanted. Well, before COVID, were transplanted within 6 months. But my concern is that if they don't get transplanted, those patients would have been offered a TACE anyway as a palliative treatment. So I just feel that I feel if the patient ends up progressing, and not getting a liver, that you've done them a disservice, because they would have got a TACE as a palliative treatment. So that is my thinking behind doing a TACE on all the transplant patients, because that would be the treatment that they would get if they weren't listed for a liver transplant.
Okay, thanks for that. I'll just see if there are more questions coming up here. Just maybe a comment. I think in both the talks, Professor Keli's talk and even Mark's talk, what really becomes apparent is that we are still grossly undertreating patients, and it's not a question of undertreating what can be treated. I think one of the major problems is the way that these patients present. Very late, very advanced disease, and often in the cirrhotic patients at a stage of sort of liver failure, where there's very little left to be done other than possibly transplantation. Other thing that is interesting is we still very much refer to the BCLC criteria when we present anything. And it's interesting to note that and we've spoken about this before, that we need guidelines, we need guidelines for sub-Saharan Africa to address this. Because if you look at the sort of Eastern Asian region treatment guidelines, none of them include the Barcelona criteria. It's not part of their algorithm. And Professor Keli, I think what is notable as well, you mentioned the large size that these patients present at in terms of the tumors, but quite a large proportion of patients, or relatively large, are actually presenting without cirrhosis, where the Barcelona criteria can't actually be applied. And the fact that some patients present very young, in terms of their functional reserve generally, is we tend to stretch the indications in terms of malignancy as well, to include patients that are size-wise at least far outside the Barcelona criteria. If we stick to the Barcelona criteria, we probably wouldn't have resected a single patient. Do you have the same experience? Professor Keli, if you can just unmute. If you just unmute your microphone.
Okay, can you hear me?
Yes, I hear you now.
Okay. At the starting of my experience, we have patients with very huge tumor, like 9 centimeters, and it was a bad time of our experience, because we undertake right or left hepatectomy, and after that, all the patients I can see die. So now when the liver function is good, and we can take two segments, for us is enough to make a liver resection. That is now our political view.
Okay.
To be more less aggressive.
Yeah. And I understand that, and I also saw, that the main problem you have is the main problem that people have all over the world, and that is that post-operative, post-hepatectomy liver failure is for us as well, is the biggest cause of mortality in not only for HCC, but also in other indications for liver surgery. Wendy, I see you were unmuted for a moment there.
Yeah, I mean, just to look at the HCC risk predictive scores also are actually weighted for cirrhosis and age, and are really not applicable to Africa at all. So the scores can't really be used in our populations either. So that's something else that we need to really look at. And I think alpha-fetoprotein becomes more important in our situation, particularly hepatitis B, where you see these rising HBV very rapidly.
Thanks. Mark, I see you had your hand up.
Yeah, I think one of the reasons why I think our transplant survival rates are better than our liver resection rates is that there's a selection bias also, you know, with the resections, you tend to just you do them quite quickly. The patients who've got more aggressive disease potentially get operated on, and also, you know, like we would do a liver resection on someone with vein invasion, but that's a contraindication for transplant. So I do think that the liver resection group is not as selected a group as the transplant group. You know, the ones that progress on the waiting list might not have done well with a liver resection. So that time period on the waiting list also selects out patients with less aggressive disease.
Yeah, thanks, Mark. Elie, we've got a few minutes left. I just want to ask you, in terms of the decision making on these patients, I saw a nice picture of the colleagues sitting around the table on your presentation. Do you have a tumor board or an MDT meeting where these patients are discussed? Or what is your clinical practice at this stage? Yeah, so if you can just unmute. Could you hear my question?
What, talking to me?
Yes, yes. So I just asked.
Okay, yes. Let's go. Wait, what do you say?
So I just asked, when you make decisions on these patients in the bigger centers, do you have a multidisciplinary team meeting with your hepatologists and the oncologists or the pathologists? Do you have that in place? Because I know that is a very, very big challenge in many countries, and certainly in South Africa, in some centers as well. We are a little bit privileged being in a big hospital. Do you have the possibility to discuss patients in a meeting before making the treatment decision?
For now, we can't have one hepatologist a week, not oncologist. But we are trying to put all patients together in a weekly basis, but is not realizable.
Yeah. No.
I want just to ask a question to Mark, please. It's about the selection criteria for transplants. I say that his criteria is University, California, San Francisco criteria. Why
Yes.
not Milan? Why?
So of the 6 patients, 4 were within Milan criteria, but all of them were within UCSF criteria. You know, if you take your 5-year survival with Milan criteria, the 5-year survival is probably in the region of about 60 to 70%. With the UCSF criteria, and this is based on overseas data. With UCSF, the 5-year survival is probably just above 50%. And you know, we're not transplanting a lot of patients with HCC, and the patients weren't waiting that long on the waiting list. So that was why we felt that we could use the UCSF criteria. So I think you got to decide, you know, it sounds like you guys are going to try and set up a liver transplant program, and I think you need to decide what criteria you're going to use. You know, there's problems with those criteria as well. They don't take into account alpha fetoprotein. So we have a 500 limit for alpha fetoprotein that's not included in there. So if someone's got a alpha fetoprotein higher than 500, we won't transplant them. Yeah, so I think it's something that each unit has to come up with.
Thanks, Mark. So, questions? I don't know if there are any more questions or comments. I think we can conclude. First of all, I want to thank the speakers. Professor Keli, thank you very much for a very good presentation, very interesting, and it's seldom that we get that kind of data, as I told you, from countries in sub-Saharan Africa. I think it's very helpful for all of us that want to take this forward. Secondly, I want to thank the ECHO team, New Mexico, and also ECHO team India that always help us with these meetings. Feedback is available in the chat, and we really appreciate any feedback to try to improve these meetings. The recordings of all these meetings are on the Gastro Foundation website, and I think Cheryl can share if there's people that don't have that link, the link with I think it's actually on the flyer for the meetings. Also thanks to the Gastro Foundation, Chris Cassanides and Cheryl and Karen that put these meetings together. Again, thanks to the presenters. And then not least, last but not least, all our sponsors, Takeda, Aquino, Amgen, Equity, Aspen, and Adcock Ingram. And then just a reminder of next week's GECCO meeting. That is going to be the endoscopy meeting, and there's going to be talks on colon cancer pitfalls in management. And then Dr. Dion Levine is also going to give us an overview of surveillance in ulcerative colitis. So again, thank you very much for attending, everybody, and I wish you a good day further. Bye.
Thanks, Ed.
Thank you so much. Again, thanks for the kind notes in regard to the update on our meeting coming up. Look forward to see you all. Thank you.
Thanks, Ghassan.
Bye, Ed. Take care.